Hello, everyone, and welcome. My name is Paige. I am part of Community Relations at Deschutes Public Library, and this program, Police and Mental Health Crisis in Deschutes County, is part of Deschutes Public Library's virtual programming. We have with us today Stephanie Saleen, Affiliate Director of the National Alliance on Mental Illness Central Oregon. She has worked with NAMI as a volunteer, a board member, and has been the Affiliate Director over the last 3 years. Sergeant Liz Lawrence of Bend PD. Sergeant Lawrence grew up in Bend and has worked for the Bend Police Department for 30 years. Captain Devin Lewis of Redmond PD. Captain Lewis currently serves as the captain of the Redmond Police Department and has over 21 years of law enforcement experience in Central Oregon. Deputy Kevin Riding of Deschutes County Sheriff's Office. Deputy Riding has worked for the Deschutes County Sheriff's Office in a variety of capacities from 2007 through today. Holly Harris, Program Manager of Deschutes County Behavioral Health Crisis Program. She currently oversees all crisis and forensic diversion services, including the Deschutes County Stabilization Center. She has been working in the behavioral health field for over 17 years. And our moderator tonight is Adam Goggins, Crisis Team Supervisor at Deschutes County Health Services Crisis Stabilization Center. Mr. Goggins will be addressing questions to the panel at the very end of the program. Thank you to all of our panelists for being here tonight. I'm going to turn it over now to Captain Devin Lewis to get us started.
Great, thank you very much for those introductions and welcome everybody to our panel tonight. We're going to get started here with our community partners. As you'll see, we've got several community partners. And when we talk about police, law enforcement, and mental health, it's not just one police department. We've got all the police department in Deschutes County to include Bend Police, Redmond Police, Deschutes County Sheriff's Office, Blackfeet Police Department, and the Sun River Police Department. Other community partners also include Deschutes County Behavioral Health, Deschutes County 911, St. Charles Health System, and NAMI, or the National Alliance on Mental Illness Central Oregon branch. So you've probably heard the term, maybe some of you have heard the Crisis Intervention Team, or CIT. What CIT is a model for community-based policing, and it brings together law enforcement, mental health providers, mental health advocates, and other partners to improve our response to mental health crises. The primary goals of CIT are to improve officer and community member safety. We want to increase connections to effective mental health services for people in crisis. We want to use law enforcement strategically during crisis situations and increase the role of mental health professionals while we're on these calls. We also aim to reduce trauma that people experience during a crisis and contribute to their long-term recovery. We're really fortunate here in Deschutes County to have our CIT team. In fact, we were recently awarded a silver award from CIT International, and that was great recognition for our community partnerships and how well we work together in trying to serve folks in crisis here in Deschutes County. So one of the ways we do this is we have a CIT steering committee, and we meet monthly. And during this time, when we meet, we discuss lots of different things. We'll talk about different cases, different system issues, and just make sure that our partnerships are working together and that we're working well together. I mentioned earlier that we became nationally certified, so we're very proud of that. And we're constantly looking to improve not only our partnerships, but our way we respond to mental health and crisis calls. And so we will be beginning a pilot program, hopefully in the next couple of months, on how we reroute some of these calls, hopefully away from law enforcement and to mental health professionals. And I'll let Holly get into that further detail as we move on through this presentation. So why is CIT necessary? Well, if you ask me, I've been in law enforcement in Central Oregon for over 20 years. I believe it's extremely necessary. We've all seen a rapid increase in mental health calls, not just recently, but like I said, going back 20 years, it's just steadily increased year after year. And so because of that, we're asking more and more of our law enforcement officers when we respond to these calls to help not only de-escalate the situation, but try to get folks connected to the proper resources as well. You can see some statistics on the screen, and you can see that in 2018, Bend PD experienced an increase of 170% in their annual mental health calls. Overall, law enforcement calls to the mobile health crisis team increased by 67% from 2018 to 2019. And in 2020, the mobile mental health crisis team had 9,497 total contacts with individuals experiencing a mental health crisis. And again, it's not just Ben PD. Deschutes County has seen an increase in their calls, as has Redmond PD as well. I know specifically for Redmond PD, just last year alone, from 2019 to 2020, our use of MCAT, the mobile crisis team, increased from 303 to 538, which is 78%. So we recognize this increase, and we're trying to strengthen our partnerships and hopefully handle these calls better and get more officers trained. Some people ask, why aren't all officers trained in CIT? And one of those reasons is it's a 40-hour class. We try to get as many people through it as possible, but on top of that, it takes thousands of hours and all these partnerships to put on that training. So it's our goal to get it at least once a year. Hopefully in the future, we can maybe move it up to 2 to 3 times a year. But again, it takes a lot of resources to put that training on. Again, overall, we believe that we are trying to handle this assignment well, but we want to continue to improve. And we realize that these encounters require specialized training and community coordination to help address these public healthcare issues. And I'm going to turn it over to Deputy Writing to talk about how people can get help.
Okay, so there's a wide variety of things that somebody can do to reach out for help in a crisis. And what crisis means for one person might mean something different for somebody else. As you can see on the slide here, there's a Deschutes County crisis line. That little yellow square there has a number that's accessible 24 hours a day. And that's a great resource for people who need to talk, need to have some intervention that doesn't rise to the arena of law enforcement. And you can go down the list there. At the very bottom, it says through 911 and law enforcement. And that's kind of where I come in as a deputy sheriff and as a street level cop here. Many people call into 911 for help with mental health crisis. Oftentimes it's on behalf of a loved one. And there's a wide variety of questions which we tend to ask. One of the things that we worry about as law enforcement is we don't want people in the mode of crisis to misinterpret what we as police officers and deputies are trying to do. So we like to get as much information as possible and try to reach out to those people and help in a manner that is acceptable to that individual in crisis. Because again, we don't want them to misinterpret what we're trying to do, and we don't want to misinterpret what they're trying to get help with. So that first call usually comes through 911 or through the non-emergency number. And then that gets assigned out depending on the agency or where that individual is or that jurisdiction. And that'll go to me or one of my partners, and we'll begin to triage that call. We get trained on, are there weapons involved? Are they actively suicidal? Have they had suicidal ideations in the past? Are they currently using substances? Are they drug addicted or anything along those lines? Because sometimes when people are under the influence of controlled substances, their behavior can be different than when they're sober or not under that influence. One of the greatest things that we have as cops is the Deschutes County Mobile Crisis Team, MCAT, and we tend to bounce off of them a lot of the contacts that we're having because we're not trained psychologists, we're not trained mental health professionals, we're cops. And so while we can communicate with people and talk to them and try to direct them in the right way, it's nice to be able to have MCAT there to be able to make some determinations above our level of education and experience. And so there are times when we need to take some action, and we try to do that as safely as possible. Other times we try to mitigate it just through a phone call and try to reach out for resources. There's a wide variety of factors that go into that type of call. The one thing that we try to minimize though is violence to us, violence to that individual, and violence to the community. And so that's why more information at the front end of that call can help us make better decisions at the back end on how to best serve that individual in crisis. We are tasked with a wide variety of calls that we go to. And because of that, sometimes we disengage from that scenario. For example, if somebody was suicidal in their house, they were actively suicidal, had made some very definitive statements about killing themselves, and they had access to weapons, but they're all alone and it's just them. We may not go in and contact that individual. We may try to call them and chat with them in that way, but the last thing we want to do is to push that individual into thinking that they're going to jail or their rights are being taken away, force them to commit suicide, or force them to have, or force us to shoot them due to their actions. That's what we try to mitigate. So there are circumstances when the risk is just too high for us to take action on, and we back out of there because it's usually in the best interest of us and in the individual, given those circumstances. If we do end up making contact with that individual and we do deem that they're a threat to themselves or to others, we can take them involuntarily to the emergency room. They get evaluated by emergency room doctors and other professionals, and further care is taken at that time with people who are trained in that arena. We can also chat with that individual about them going voluntarily to the ER. And that sometimes works because it's puts them in hands of people who, again, are trained in that arena. And the other thing that we can do is we can have MCAT come out. It's difficult to do an evaluation when somebody is intoxicated. And so sometimes going to the emergency room so they can detox or things like that and then be evaluated is best. There is now, fortunately for us, a place called the Stabilization Center that just opened. And it's a place where people can get immediate care, both medical and mental health and some other services. So if an individual, depending on, it doesn't matter what walk of life or what their circumstances are, that's always an option. The Stabilization Center is great because you don't need the police to take you down there. That person can walk in on their own. Family members can take them in, or we can, a friend, and they're there to help. And so they make those evaluations and determinations. What we're trying to do right now, just in society in general, is we're trying to build relationships and trying to figure out who in our community are at higher risk when they have these moments of crisis, so that we can have MCAT already have a relationship with them, so that when we talk to them, they may say, hey, I only want to talk to Sergeant Liz Lawrence, or I may only want to talk to so-and-so. That's a good relationship. And we try to cultivate that throughout everything that's going on so that that can continue on and we can get them the care without any violence. So.
All right, I'm going to talk a little bit about what Bend Police Department has when we started. This idea started in 2015, and actually sometime before that, where we dedicated resources to just respond to folks in crisis and help them with resources. So in 2015, we put a team together, and Keisha Weaver, who still works in the team, Officer Keisha Weaver, myself, and another officer began responding to crisis calls. And we know that as Deputy Riding said, crisis looks different for everybody. And sometimes along with those crises, there's co-occurring addiction issues. So we decided to reach out to people in our community, Turning Points, Pfeiffer and Associates, Best Care, and started building those bridges and relationships with our community partners so that we had resources and peers that we could call. And eventually, and as I'm sure that Holly will talk about, there's peers that work at the Stabilization Center and with MCAT, and they're a great resource in the field too. So along with Bend Police Department and Deschutes County Behavioral Health, we came up with a co-responder program. It's been fabulous. Abby Levin works with the community response team. She deploys with us out in the field. She rides with us. We make sure the scene is safe, and then she can go in and engage people, and she can talk about resources that are available, or at times if somebody is so dysregulated and unable to be safe that she may have to put a director's custody on somebody and ask us to take them to the hospital for treatment. And once they're able to be stabilized, there are other treatment options available, and she can offer all those, and she checks back, as well as the crisis team checks back with people to see how they're doing in community. We do the same thing too. Once our clients are back out, we check with them to make sure they're doing okay, they have their medications, they don't need rides to appointments, because we just don't want to be the face that they see when they're in crisis. We want to be able to see them when they're doing well too. And it builds these great bonds and relationships, like Kevin said, that are really unbreakable. And at the time when they're having their worst crisis, they actually have a face and a person they can talk to. That's super important. And in the end, can we fix everything? No, but we can refer those people to resources and their families, because we make connections with the family members as well. So it's all encompassing. You start at the Stabilization Center if they go there voluntarily. You have the peers, the therapists, mobile crisis, and then if something happens out in the field and someone calls dispatch 911, the emergency system is activated and the call goes to the police. And hopefully one of us who've been trained, Kevin or other people in the field, can respond to that crisis and know the appropriate actions to help that person find a place to go that will help them find stability and help with treatment. Because really in the end, people just want to be able to live their lives. And if we can offer some semblance of support and a friendly face that tells them, I hear you, I see you, and I want to offer some services to you, makes a big difference for everybody. And so pictured there is Marshall, the therapy dog. He works with my unit, and we're also in the schools. And he was just visiting Ensworth Elementary School recently and hung out with the life skills kids for quite a long time. And that builds relationships too, because some of our folks in community may have a mental health disorder with a disability. And sometimes when they go into crisis, if they know somebody who's been to the school or has been involved in the community, they'll remember that person in face, or they'll remember the dog's name. They may look at me and say, Marshall, which is my dog's name. That's okay. That builds rapport and community that is priceless, in my opinion. So he's been a helpful tool for us too. And he's gone to court with some clients that have had a lot of anxiety or PTSD about appearing in court. And so that's another helpful bridge for us to gap. But the co-responder program has been a big deal for us. Holly, are we in our third year, I believe, of the co-responder program? It's a 5-year grant. And I'm hoping that when this grant expires, that we're going to be able to replace it with another co-responder, at least another grant. And I would like to see it expand throughout the county. And quite frankly, my pie in the sky idea is that it would be great to have, just like we have a drug team that focuses on many areas, to have a mental health team and available officers that focuses on many counties and areas as well.
Hi, everyone. I'm going to talk to you a little bit about the Mobile Crisis Assessment Team, otherwise known as MCAT, that you've heard about already. And I just have to say to Liz, we love Marshall at the Stabilization Center. He's made many visits over here as well. And boy, does it lift our staff's spirits every time he comes through the door. So we love Marshall. But the MCAT team, we're really fortunate in Deschutes County that we've had a mobile crisis team for about 17 years. So we've been ahead of the game with having that resource in place. It only recently became required about 2 years ago for every county to have one. So this is a team of master's level clinicians. There's 6 total. They work in teams of 3. They work 24/7, 365 days a year, and they cover the entire county. And so they respond to individuals in crisis, and they're oftentimes called out by law enforcement, but we are also called out by primary care clinics, schools, assisted living facilities. We go to the jail. So just a number of places that we respond to with and without law enforcement. Currently, if responding to someone's home for a welfare check does go through dispatch and does trigger kind of what Liz and Kevin were talking about, a police response. But as Captain Lewis mentioned, we are in the process of developing a pilot project that we hope to roll out this fall, where dispatch will actually directly connect calls to the mobile team, certain criteria of related calls that we will then respond to or handle on the phone if possible, but if not possible, dispatch teams of 2 to respond to those calls. So that's in the works and should be coming soon. We're very excited about that. MCAT's a very busy team. They respond to nearly 10,000 calls a year. That has gone up about 40% for the last at least 5 years. Each year it's gone up about 40%. So huge increase in calls. Some of that is related just to our reputation in the community and being more well-known each year, our relationships with law enforcement, them calling us a lot more than in years past. So all of that plays into it, but then also just the rise in population and the rise in mental health calls. So here's the Stabilization Center, which is the next thing I'll talk about. So as many of you probably know, the Deschutes County Stabilization Center is a collaborative project that started about 6 years ago with the collaborative project between the Deschutes County Sheriff's Office and Health Services. We since have lots of collaboration with our other community partners, our Redmond Police, our Bend Police, all NAMI partners, everybody's sort of a partner in this now, but it started with the Sheriff's Office. And the goal always was to develop a 24/7 crisis stabilization center with 23-hour respite. And I'll get into the details of that in a minute. We opened right smack dab in the middle of the pandemic, which was really interesting, as you can imagine. But so glad we did, because we were a very critical resource during a very difficult time, as most other resources were dropping to half capacity or not at all available anymore to our individuals in crisis or dealing with serious mental illness. We were at one point in time the only county building open to the public providing face-to-face services for about an 8-month period of time. So it was really great that we decided to open when we did. I think it was a critical need that we filled during that time. So we are a 24/7 operation. The unique thing about this program that's different than other programs that we looked at is that we take both crisis walk-ins. So anybody of any age can walk in if they're experiencing a mental health crisis, and they can be seen by a clinician. And we also take law enforcement facilitated drop-offs. So this is an opportunity for law enforcement when they're out there engaging with somebody to say, you know, we've got this voluntary facility. If you'd rather go there, we can take you there instead of the emergency department or in lieu of jail, oftentimes if it's low-level crimes, and they can be diverted to the stabilization center. And that's really what we want to see happen. So we are open around the clock. So holidays, Thanksgiving, Christmas, all that good stuff. We are here working and ready to serve people in need. And you can walk in any time of day or night, whenever you're experiencing a crisis. And a lot of times I get asked too around if it's just for Deschutes County. We are a tri-county resource. About 4% of the people we serve are from Crook County, 1% are from Jefferson County. It's a little further. But we actually, I always say we're really open to anyone. I mean, you can be from Canada, and if you're in Deschutes County having a mental health crisis, we're not going to turn you away because you're not from Deschutes County. You know, we're going to serve anyone who's in our county that's in a crisis. So I just want people to understand that. So the goals of the Stabilization Center have been the same since day one. One of the primary goals is to reduce the number of individuals that are utilizing our emergency departments for a mental health crisis. I think, as all of you can imagine, emergency departments were really never intended to be a mental health crisis resource. They are in the business of, you know, dealing with heart attacks and broken bones and major traumas. And it's a busy, chaotic environment where you really don't want to be in there longer than you need to be. And so having a mental health crisis being dealt with there is just not quite as trauma-informed as coming to the stabilization might be. And we really want to use our emergency departments for the most severe types of cases due to capacity. We also want to help people experiencing a mental health crisis stabilize in their community, in our community, and become connected to resources so that they engage in treatment and ultimately regain a quality of life that they deserve. And I think that's where the Stabilization Center really differs from an emergency department, in that we're not just going to see you and send you out as quickly as we can because we've got a heart attack patient waiting on the other side. It's really that we're going to spend the time with you to figure out what you need. We're going to actually make the connection to those resources. We're going to do follow-up outreach and engagement to make sure that you're able to get to those resources and that there's not barriers in your way. We can get you connected to insurance and housing resources and all of those things that sometimes drive these crises. So it's just that extra layer of support that most people need in navigating this very complex mental health system. So another one of our goals is to, this is a big primary goal of why we developed the Stabilization Center. And I'll get into kind of how we got to this state of the universe in a minute. But we really want to reduce the number of individuals with a serious mental illness who are ending up in our criminal justice system, ending up in our jails every single day, ending up in our prisons, and really by no fault of their own, other than that they have a mental illness that's causing them to act out and come to the attention of law enforcement. I think it's really one of the travesties of our country that we need to figure this out and we need to do things differently. And things like the Stabilization Center really give law enforcement an alternative place to bring people in lieu of the jail, so that we can get them connected to all those resources and hopefully prevent them from coming to future attention of law enforcement. We also, this is a big goal of ours as well, to provide a place for law enforcement to quickly bring someone in crisis so they can get back out to their duties, protecting the public like they do best. You know, law enforcement, when they take somebody to the emergency department, they can spend hours waiting for somebody to be evaluated because it's a capacity issue. Our goal when we opened the Stabilization Center was to have law enforcement in and out of our building in 10 minutes or less. Not the individual, but law enforcement. We have been averaging 4.7 minutes or less per law enforcement drop-off. And so really the way we like to operate is kind of a no wrong door policy. I mean, as long as the individual isn't involuntarily being brought to us, because this is a voluntary facility only, and they're not being actively assaultive, law enforcement can bring them to us. And if we determine after an assessment that, well, they really need this other resource or this other place, we're not going to have law enforcement hang around and wait for us to figure that out and then take them there. We're going to say, law enforcement, get back out, do what you need to do, protect our community. We'll take it from here and we'll figure it out. And that's really a key difference in how we operate. And we really try to come from a place of yes, and really support our law enforcement partners and not having to be the primary social workers trying to figure out if this is mental health or substance use. Well, and before we get into the floor plan a little bit, I often get asked, like, how did it come to be that people with serious mental illness are ending up in the criminal justice system? And many of you may or may not know, but back in the 40s, 50s, and 60s, there was a big push to deinstitutionalize mental illness, which made a lot of sense at the time because people were being put in asylums for sometimes their whole life in pretty deplorable conditions. There were some major atrocities happening in asylums back at that time. And with, the advent of new medications that made treatment outside of a state hospital more possible and outpatient treatment being more accessible and the advent of Medicaid, it really became possible to say, we really don't need to do that. We shouldn't be doing that, quite frankly, which I think everybody can agree with. Unfortunately, what happened, though, is there was a mass deinstitutionalization. Beds were cut drastically. And unfortunately, the money didn't follow communities to be able to then do the work in a local setting. And so what ended up happening is really trans-institutionalization, which they just ended up in a different institution. And unfortunately, some of our prisons across the country became the largest mental health providers in the country. I think Rikers and LA County were some of the largest mental health providers in the country, which is, I don't think anyone's intent when all that happened. But it's one of those unintended consequences that we're working our way back from and trying to find alternatives like the Stabilization Center, like co-responder programs, like mobile crisis teams. All of that work plays into this. So as you can see, this is our floor plan for the Stabilization Center. And we like to show this just to kind of point out a few things. We have a separate public entrance where anyone of any age, children, adults, families can walk in any time of day or night and receive and meet with a crisis clinician. And that's a separate public entrance. And then for our law enforcement partners, we didn't, want necessarily them having to come through the public lobby in uniform and all of that. So we have a separate private entrance for law enforcement with separate intake rooms in the back where we can see the folks that they bring us. And again, getting them in and out in 4 minutes or less. And as you can see, there's recliners right there. So that's where our 23-hour observation unit is, which I'll talk about a little bit more in a minute. And it's really a pretty simple concept of recliners to get basic needs met and get sleep, food, shower, those types of things, so that then we can figure out what's really going on and how can we best support an individual once they've gotten those basic needs met. Next slide. So here's some pictures of our facility. We're really proud of it. We worked really hard to try to make it a homey, welcoming environment. We tried not to have it feel institutional. There's water features. There's, more trauma-informed colors. It really, I feel like it's a pretty welcoming environment, and our clients have felt that way as well. We have a family intake room where we can see children and families and have some toys for kiddos there to make it welcoming for them. And if you'll notice, we have 2 doors on our intake rooms, which is really what we call a trauma-informed approach, where both staff and clients feel like they can leave at any time. This is again, a voluntary facility, so anyone can come and go as they need to. And we always want people to feel they can leave at any time if that's what makes them feel safe. So here's our respite unit. And this is really what the game changer was, because we've done crisis walk-in for a number of years at Deschutes County Behavioral Health. But the big change was that we can now do it 24/7, which I think is huge. We don't have to have people have their crisis between Monday and Friday, 8 to 5, which is lovely. So now anybody can come in whenever their crisis is happening. But the respite unit is the other real game changer. And like I said, this is only about 20% of the people we serve end up needing the respite unit. But the people that need it, it's really changed their lives from the reports we've gotten from clients who've actually been in there. It's a space where they can just get some rest they can sleep, they can get some quiet space. There's a water feature in there as well. If needed, they can get a shower. We can launder their clothes. We can get them some food. And really just an effort to just meet those basic needs. And then once that kind of de-escalates to a point that they feel is manageable, then we can start to talk about what are the next steps? What do we need to do? And what are their appointments that need to be made? Do we need to get their OHP set up? Like all of those kind of more tedious tasks that need to happen, but are difficult to do in the midst of a mental health crisis, especially if you're experiencing houselessness and haven't been able to even get your basic needs met. And
Okay.
I'll pass it over to Stephanie.
Thanks, Holly. So we've heard about all the different programs that we have going on and how law enforcement and crisis teams kind of work together. And I'm going to discuss the consumer perspective as far as representing individuals who have worked with law enforcement, worked with the crisis teams, what some of the barriers are, what some of the supports are, and kind of how we can, what we see moving forward in our community. But first, I want to touch about National Alliance on Mental Illness, NAMI, what we are and kind of our credentials and how we can represent the consumer population of Central Oregon. So for those of you that are not familiar, NAMI, the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization. It was formed in 1979, and the Central Oregon affiliate was formed in 1984. It was fully volunteer ran until 2020 when we transitioned to have a paid staff because we realized that the need in Central Oregon was growing and we weren't able to fully support the community that we needed to on a strictly volunteer basis. So NAMI's mission is to provide advocacy, education, support, and public awareness so that all individuals and families affected by mental illness can build better lives. These are just a couple of pictures that we have from events. We try to go out to community events and talk about NAMI, talk about our support groups, talk about the programs that we have to offer. We offer free educational programs that are evidence-based. Our national organization takes evidence-based programming from SAMHSA and other organizations and puts together trainings. We have one that's called A Family to Family, and it's an 8-week course that really helps families understand what their loved ones are going through with their mental illness and what crisis kind of looks like and how to best support them, communicate with them, and how to support themselves. Because going through crisis for an individual is very stressful, and it's also very stressful on the family. And so we want to make sure we take a well-rounded approach in supporting everybody affected by mental health crisis. And then there's a picture of Sergeant Lawrence and Officer Weaver and Marshall, and they're there supporting one of our community events that we hosted called Stomp Out Stigma, where we try to just get out in the community, break down the stigma, bring awareness around mental health and mental illness and crisis. So we'll go ahead and move on to the next slide, please. Thank you. So when looking at consumer perspectives, these are some questions that I sent out to individuals who have been really active with NAMI, whether it's our support groups, they lead them, they participate in them, they've gone through some of our trainings, they reached out for support or help. Individuals who either have gone through mental health crisis themselves, or they are a family member or loved one of somebody that has gone through crisis and specifically has worked with law enforcement and these programs and MCAT and the crisis team in the past. So the questions that I kind of put out there to all of these individuals were these 5 questions. What is it like to ask for help during a crisis? What are barriers for individuals during a crisis? How can individuals and family members get the support they need during a crisis? What have been the best supports for you when navigating a crisis? And is there anything that you learned while going through a crisis that you feel would be important for others going through a crisis to know? And I received a wonderful amount of response and information. And so I kind of read through all of those from these individuals and pulled out the trends or common themes that I was finding. And the main thing, both families and individuals answered what it's like to ask for help during a crisis on both sides of the consumer perspective. I heard a lot of shame. There's a lot of shame. They're scared. Family members aren't really sure when they need to actually reach out and ask for help. When is it appropriate? Are they calling too soon? Do they call too late? There's just a lot of uncertainty. And the individuals that have gone through the crisis themselves feel shame. They feel like people aren't going to understand what they're really going through. They're not going to have help, or they don't realize they need help in the moment. Some barriers that we have really found for individuals going through a crisis are, again, just not understanding the process. A lot of our families in our support group come to us confused, upset, frustrated, because they're not quite sure how the actual process works. They feel like my loved one is in a crisis. They need to be sent somewhere, put on medication, stabilized, and helped. And there are a lot of pieces to the puzzle. It would be great if it was that simple, but it's unfortunately not. And, law enforcement has their processes and protocols. The crisis teams have their processes and protocols. And so we get a lot of that kind of frustration in our support group. And so those can kind of be barriers for the family members and helping their loved ones. So that's something that NAMI does, is really try to educate our family members on the processes. We reach out frequently to our community partners to better understand ourselves, what the process is, what it's going to look like when someone's in crisis, how people are going to respond, what the families can kind of expect, what the individuals can kind of expect. And we try to pass that along in support of our family members in the support groups that we offer. So how can individuals and family members get the support they need during a crisis? The responses that I was really getting from this is reach out. If you're really not sure, reach out. You can call, when you call dispatch, if your family member's in crisis, let the dispatcher know that it's a mental health related call so that they can reach the appropriate team. Holly had mentioned earlier that they're hoping to roll out a pilot program where they can dispatch the crisis team automatically. So this is extremely important when that program rolls out, that when your family member is in crisis, that you make sure to let the dispatcher know that it's mental health related. The best supports that have been when navigating a crisis across the board, I've gotten back from the responses, have been the crisis team and the law enforcement officers that are trained on our CRT team. Typically, families who have loved ones or individuals that have gone through crisis don't just go through one, they go through them more than once. And so Sergeant Lawrence was talking about building rapport and making people feel comfortable with certain officers. So, just the supports that we've heard about is our crisis teams and the law enforcement support through the CRT team. Having the co-responder program was a big piece that I received back in my feedback, is that that's been really helpful, having a mental health professional respond with the law enforcement officer to kind of help provide services in the now, right in the moment. Try to get resources, try to get support, try to get people lined up has been the best support. And then as far as if there's anything that they've learned while going through a crisis that they feel is important for other individuals to know, the biggest thing is advocate for your loved one. Be a squeaky wheel. That's one of the things that I got back. Sometimes we feel like maybe we're pushing a little bit too much, but our loved ones rely on us to advocate for them and help support them. And so be that squeaky wheel, make that be that advocate, make that call, has really been the feedback that we received. Also, just breathe. Crisis doesn't last forever. People go in and out of crisis, but it's not going to continue on. So just know that, there are a lot of supports out there. We have, as you can see, a huge team of people within Deschutes County that work really hard 24 hours a day to try to support our loved ones and ourselves that go through crisis. So just reach out to those resources, get the support you need, and breathe and work through the crisis. So I think that's all I had from the consumer perspective. Thank you.
All right, and I think that officially ends our presentation section of tonight's event. And so the next portion is really just going to be a question and answer section, which we've had a couple of questions come in before tonight, and also just kind of as tonight has gone on. So if you have any questions, there is, I guess, a Q&A button that you can submit questions. I can go ahead and review them, and I'll ask the panelists what those are. One question that came in tonight was, and this is probably for Captain Lewis, Sergeant Lawrence, and Deputy Riding. When law enforcement is dispatched, do you ever consider sending an officer not in uniform to help ease someone's stress level? Has that ever been a discussion point?
If I can jump in here. So again, this is Liz. And I think our approach was this. I know people have trauma in relation to some contacts with law enforcement. However, on the same point, I want them to realize that with all this comes a person that you can build a relationship with, that can see you, hear you, and help, or get resources that can help. I can say easily, since I've been doing this work since 2015, I have never had a person tell me, I'm not going to speak to you because you're in uniform. So again, it's how you approach people and your compassion and empathy. And I think, Kevin, you would probably say the same.
Yeah, I would say the same. It's difficult. I don't, in the county, it's a little different than the city. The cities are relatively close together. In the county, we're spread all the way out. So it's difficult, depending on that moment of crisis, to get somebody not in uniform. But I don't think it's the uniform so much as how you treat people. I've seen all walks of life, very rich individuals and very poor individuals. And at any given time, my life could fall apart and I could be in the poorest of circumstances and just need somebody to talk to, regardless if they're the, garbage man or garbage woman or a CEO of a major company. What matters more, I think, is how we treat one another, especially in that moment of crisis. So regardless of what we're wearing or our beliefs or whatever that is, it's how we treat people. And when we as deputies and officers treat people with respect and have that open dialogue prior to, we can build that up. There's been many circumstances, I don't have time to go into them, where we have severely ill people in our community who remember how they were treated by the police in a good way and in a bad way. So I think if we build up that in a good way, that pays itself forward dividends, which keeps me safe, keeps them safe, and they remember those moments. So.
All right. So this question, we've kind of alluded to this previously. What examples are there of successful programs where police and mental health workers have worked together? I guess this could be for anyone.
If you're saying in general, there are many law enforcement agencies across the country that have navigated systems, law enforcement working with mental health or with social workers or even peers. I went down to Los Angeles and met with LAPD and toured their facility where they actually also have embedded social workers in their detective units. So it's very well known, widespread, and the same thing across the country. You can find that there are other organizations that have similar co-responder programs, or there's a model in Texas where they actually have the social worker in dispatch who can help go through the calls as they're received and say, this doesn't look like this is a law enforcement response, and send them to different resources. So I think in general, you don't hear a lot of discussion about what's in place. You hear a lot of what people would like to see, but they really don't know the truth about there are some of these models in place and working well in community. And Holly, I don't know if you want to jump in about this and mental health and law enforcement.
Yeah, I mean, I think there are lots of ways it can be done. And I think there's a lot of talk around the Cahoots model, which is a wonderful program out of the Eugene area, where they are taking calls directly from dispatch. But there's more than one way to do this work. And I think it's really dependent upon what the needs are in your community and what population you're serving in your community. And so in Deschutes, we've had lots of discussions about this. And the Cahoots model, it really pairs a medic with a caseworker, and they're responding primarily to people experiencing houselessness and substance use disorders. And that is definitely a population we respond to, but it's not the vast majority of the population we respond to. So we're responding to a wide variety. And so really the medic piece for us didn't feel entirely necessary. So what we're trying to do is pair either a case manager or a peer support specialist with one of our mobile team members so that they can go and respond together, because in our community, that seems to be the bigger need. And I think Cahoots, while is the kind of the national buzzword right now, I think but the spirit of what everybody's trying to get at behind Cahoots is just that we're sending certain calls to mental health workers in lieu of law enforcement. And I think there's, like I said, lots of ways to go about doing that. And there's some really wonderful models across the country.
Awesome. So this next question is for Captain Lewis, Sergeant Lawrence, and Deputy Riding. What bridge building and training is provided for PDs and county mental health on understanding the needs of youth and adults with intellectual and developmental disabilities experience a behavioral health crisis? And this would probably apply for Holly as well.
I'll jump in real quick, just from our perspective, because we are seeing a lot of co-occurring IDD and mental health. It's becoming more and more prevalent in the work we do. We serve a lot of folks with IDD co-occurring issues here at the Stabilization Center, and MCAT has lots of contact. So one of the great things about our CIT program, which we talked about earlier, is that we do have an IDD representative on that steering committee that can talk specifically to the issues and the resources that are available to folks with that. And we have, in the mental health side of things, we have regular trainings that are offered to us to work on that. There's actually one coming up through the Criminal Justice Commission that we're going to be taking. That's a really good one to help find creative ways to work with this population. It's challenging because the systems are so different. The IDD system is so different than the mental health system in terms of the resources and how they operate. So it's just a learning curve to kind of know how to access those resources from both sides. But I think we have good relationships with our IDD partners, and they're at the table with the CIT training. They do part of the training, that 40-hour week, to give that to law enforcement. So I'll defer to my law enforcement partners on what else is being done.
Devin, do you want to talk about the CIT component? And, for us, it was really important to reach out to the community for adult protective services and ask them, could you come in and educate us and give us some tips about how it would be best to contact people that they feel comfortable? And, for example, we have some care facilities with folks that have autism or experience autism. And sometimes the only way they can calm down when they're not feeling well is to take a walk. And so I learned specifically what color Gatorade some of those clients liked and would just walk with them, whether it was 5 degrees, 30 degrees, 85 degrees, until they felt comfortable to go back to the facility. And they always did. Calm down, take a breath, walk, and then we're able to go back to the facility. And I know too, Devin, in your area, that you've experienced some of that with some of your care facilities there.
Yeah, and I think going back to the CIT program, that's probably our best training that we have currently for our law enforcement officers. As we mentioned earlier, it's a 40-hour course. It's very intensive. We cover lots, a variety of different, mental health issues, and including what was talked about in the question earlier. And I think we get that exposure in that training. We do on-site visits to different facilities, different care facilities around the area as well. So we get to experience that firsthand during that training. And then post-training, I think it's important that we also include, CIT refreshers and updates with our annual training. And we also focus on just trying to find officers that have the empathy and that active listening and those great communication skills, because ultimately, and I think everyone on this call would agree that when we're out with these folks, really that's what it takes, is just being that caring, empathetic person that can listen to them and kind of let them work it out. And like Liz said, sometimes it is just taking a walk with them. Sometimes it is just listening to them, a different color of Gatorade, maybe, getting them out of where they're at and into a different room. But ultimately, that's what we're looking for.
Yeah, if I can jump in just real quick, I think we just, that question probably stems from that case. I'm not sure. I think it was in Colorado with that elderly female where, she walked away, she had dementia. And this isn't Colorado. I've never worked in Colorado. I've never worked anywhere else other than Deschutes County. But I know everybody with Bend PD very well. I know cops with Redmond PD and in my own county. I think when we deal with those types of calls, more information is better. And so when it comes to training, I know that NAMI's come to our agency. I know we have continual training annually with how to recognize folks with developmental disabilities, to include autism and other things, turning your lights off, speaking in low tones, or whatever that looks like. And it gets difficult at times considering the wide variety of calls that we take and the wide variety of people that we deal with. However, when we get that information up front, whether it be from just a random person, hey, I think this young man has autism and he needs some help, or whatever that looks like, I've seen, and I can testify that the majority of the police officers and cops that I've run into, we have family members or a loved one who have similar disabilities. And so that is somebody else's child, that is somebody else's son, daughter, friend, whatever. And I know that we try to take those things seriously, because how we interact with that person, again, can build trust with that individual. Even if they do have some developmental delays, they're going to be a victim of a crime later on, possibly. And we want them to have some rapport and built up with us. And so that's something, especially in today's day and age in law enforcement, that we take seriously, and we continue to train on that. And we talk about those things amongst ourselves. Hey, there's a house down the street. That individual has, they're deaf or they're blind or they have autism or Asperger's or whatever that looks like, or this individual has dementia. And we'll hear cops that have worked their districts for long times who know those people, know those contacts. And that means a great deal because we can handle that more appropriately. I hope that answered that question.
And kind of a close follow-up for this for Captain Lewis, since he kind of mentioned CIT training and stuff like that. What does the training for law enforcement look like specifically for mental health individuals? And has that changed with the resource of the Stabilization Center?
Yeah, I'm not sure if the training with the Stabilization Center has trained per se, but again, that CIT training, it is intense. It's what we want to get out to all of our officers. Again, I talked about the partnership and the coordination it takes amongst all of us. Like I said, it's hundreds, if not thousands of hours to plan one of these courses. It's an intense 40-hour course. We usually do it offsite. There's a lot of scenario-based training, with clinicians, using experiences that they have, site visits and things of that nature to help us law enforcement officers get that training. And Sergeant Lawrence can probably speak on top of this as well. I know she does trainings over at DPSST, which is our academy in Salem, Oregon, for all law enforcement as well. We are trying to grow that program and get it out to all of our officers. I think the key with the Stabilization Center is it just gives us one more resource. Instead of being forced to have to take somebody to the ER or maybe to jail if it's a low-level crime, or maybe not having any other place to take them, now we have a Stabilization Center where we can offer that solution, that alternative, and get them hopefully the care and services they need. And so I think that combined with the CIT training, we're seeing a better response with our law enforcement officers to these types of calls. But again, we're constantly trying to improve, and we're always looking for new resources. And that's kind of why we're looking at this pilot project as well.
So the next question, I think, could be for potentially Holly and for Stephanie. So what are some proactive measures that Central Oregon communities can start taking in order to get ahead of a crisis before it would require police intervention? They were speaking specifically about houseless neighbors in crisis, but what more do we feel like could be done to help to prevent a crisis from occurring kind of in the first place?
You want to go, Stephanie, or do I go after you?
Sure. Yeah. From an NAMI standpoint, I think education is really important. It's hard with the homeless, the houseless neighbors, because you may not know them, you may not know their circumstance or their background, if they are having a mental health crisis, if it's substance use, if there's substance use involved, things like that. But if it's a loved one or a family member, a friend, I think, educating yourself on the mental illness that would lead them potentially to crisis, having a safety plan in place is really important. Again, understanding the process, because that's what we see from a support standpoint, is just the lack of not communication, but just understanding how different agencies have to interact with each other. The Oregon law is really strict when it comes down to getting help for people in crisis. And it's very frustrating for individuals going through crisis themselves and their loved ones. They have to prove to be imminent danger to themselves or others in the moment before we can actively do something, take them somewhere to do something. And if they don't prove that they're in imminent danger in the moment to themselves or others, it's really hard to get them to any sort of treatment without them voluntarily going. And again, a lot of times people in crisis don't realize that they're in crisis. They don't know that they need help, or they don't think they need help. And so getting somebody in crisis to voluntarily go in somewhere is not an easy task. So I think just educating yourself on Oregon law, educating yourself on the mental illness that your loved one or friend or whoever has is important. Those safety plans are really important. Holly, correct me if I'm wrong, but I believe, individuals, you don't have to be a person going in or in crisis to go into the stabilization center. If you have a loved one that has been going in and out of crisis, you can reach out to the stabilization center. They can give you some kind of tips on how to handle those situations the best way possible. I think just really reaching out and utilizing the resources that we do have already available in this community is so important.
Yeah, I agree with everything Stephanie just said, and just reaching out to the people that understand these resources and all the processes that Stephanie talked about earlier, because there's lots of layers to what can or can't be done with this process or this resource. And so really, I will say one of the real strengths of the crisis team and the stabilization center and all the folks on this panel is that their knowledge and understanding of those resources and the barriers to accessing those resources and how to navigate that, and helping support families and clients with that. As it relates to houselessness, I mean, that is one of our biggest challenges, I would say now here in Deschutes County. We're certainly seeing that more and more. And I'm so grateful for the low barrier shelter that just opened, and for the potential hotel in Redmond that's going to be opening. I think those are the things that we need right now. I know they're not long-term solutions, but we need short-term solutions right now. And so those are really, I'm already seeing in just the 2 days a major difference in what we're able to access and get people just their basic needs. I go back to that a lot, but getting people's basic needs met is critical to being able to help them in their crisis. I mean, you're just not going to make much headway when they're just trying to struggle to survive. So I'd say advocacy, education, and just, we really need to advocate kind of at a state level around some of these issues as well. And there's a lot happening at the legislative level right now that I think is really positive. And I hope, we'll see how it all plays out. But I just really, it's a statewide crisis. It's not just here in Deschutes County by any means. And I just think the more we stay informed as to what we already have and where the gaps are and where we need to go, the better.
So next question is, I think, for Holly. What percentage of the mental health response system is adequately funded? If the cities in Deschutes County fully funded the need, how much money is needed to really address this critical service?
That's a great question. It's a big question. What I can say that I know off the top of my head is that we need $2.5 million to fund the Stabilization Center to keep it open at its current operational level. We have used grants to do that up to this point. We will always continue to look for resources that are available out there. There may be money coming from the legislature, or there's a big crisis funding bill that's being discussed right now, which I think everybody knows the crisis system and the mental health system is underfunded in general. There's lots of advocacy every year at the legislative level to try to change that. Unfortunately, what often happens is one bucket, one piece of the system gets money one year, but the other system then doesn't get funded. And as we all know, like, unless you have the continuum funded fully, you're going to find there's going to be gaps and shortfalls, and people are going to fall through the cracks in those areas. In order to do a full kind of cahoots-ish type model of like responding to a wide variety of calls without police, we need additional staff, and we have to be able to send social workers and therapists to these calls in pairs. We cannot send people there alone, because most people experiencing mental illness are not dangerous, but there are people that are so dysregulated that they can become dangerous, and we really need to at least have two people and still be able to have our law enforcement response for those situations that are dangerous. We need a continuum, I often say. We can't just have one thing or the other. We really do need all of it. And unfortunately, that does get expensive, but it's actually significantly cheaper than not having it. Because what we've already seen with the Stabilization Center is a significant amount of savings in not only law enforcement time, but emergency department utilization. I mean, we're averaging 20 to 30 emergency department diversions a month at a cost of about $1,500 a visit. I mean, you can do the math. Annually, it comes to quite a bit of money that's saved. So I think, I can't give you an exact number of what it would cost to fully fund the system, because parts of it come back down to workforce as well. There's a pretty critical shortage of behavioral health workforce right now happening across the state. And so we need to find ways to incentivize this work, bring quality professionals into this work, and make them want to stay and do this work. And so that's an area for focus as well. So it's much bigger than just like $1 amount. But for the Stabilization Center, we definitely do have that dollar amount.
And Holly, if you don't mind, I'm just going to jump in here as a little reminder. I read this question earlier and I was thinking on it. It would be great if we could just come up with a lump sum of money and it would, put it to the problem. But I just want to remind everybody that's watching this that Holly, you kind of touched on it. There's a lot of pieces to this puzzle. Say we get say it's $10 million, right? And we get that $10 million. Well, what are we going to do? We don't have the space. So we don't have the resources. Where are we going to put that money? So there's a lot of pieces that we really have to look at when trying to figure out how to solve the crisis of crisis. Holly was talking about getting, qualified professionals in there to help these people. How do we incentivize people to do this? Where are we going to put people? One of the main things that we see through NAMI is just the lack of beds, the lack of place to put someone. If somebody gets through the Oregon law, which I kind of talked about as stringent, okay, so Oregon agrees they need help, and they need help right now. Where are we going to put them? Beds are full. Everything's at capacity, especially with the pandemic and COVID. Things have had to kind of parse down. And so we need to look at money. We need to look at space. We need to look at changing or adjusting Oregon laws to help this population a little bit more as well. So it's a big puzzle. I think a lot of people are really working on it. Advocacy at the legislature level is important. NAMI is very involved with that. So if anyone's interested in joining that, reach out to us and we can get involved. The more people that go share their voice, share their concern, the more change we can hopefully affect.
This next question, I think, be for Sergeant Lawrence. Do school resource officers, or SROs, in schools receive CIT training?
That's a great question. And yes, they do. We're trying to get all of our officers through CIT training, and currently our SROs have been through CIT. The other component to that is with our co-responder program, I made a promise to the school district that if we have any kiddos that are experiencing suicidal ideation, that we will follow that child to the home, meaning we will contact parents, regardless if it's in Deschutes County. It doesn't have to be within the city of Bend. We'll make sure that the home is safe, that the parents are engaged along with our co-responder to make sure that there is a good plan, because we know that school counselors can't leave the schools and after hours and go to the home and do those things. So I've made a promise to our district that we would do that so that we could help people stay safe.
The next question can be for potentially any of our law enforcement officers, but particularly for Deputy Riding. So if my roommate is threatening me and I call 911, how would you determine whether to send a mental health worker with an officer, if she, especially if she is the one having the mental health crisis?
Can you hear me okay still?
Mhm.
Okay. That's tough. Well, the more information on that, the better. One of the main things that we get concerned about is safety. So if that individual has a weapon, if that individual has shown suicidal ideations, within a short time frame there, or homicidal ideations, we would encourage that individual to leave the residence if they can safely do so. And that's where law enforcement really comes in, and that's that safety piece, because sometimes those moments of crisis are either on the ramping up or they're ramping down. So the more information we get, the better. If that roommate knows that they have a mental illness, if that roommate knows that they're not taking their medications, if that roommate can describe to us what they've done in the past, what they're currently doing, what the layout of the house looks like. There's two triage points there. One is a very tactical, strategic point to that, and the other one is a very mental health triage. And so there's a wide variety of information. The main thing for us initially as law enforcement would be, is that individual safe? Can we come in and talk with the mental health counselor? Because what I don't want to do is I don't want to show up on scene, have them have a hidden gun or a knife. I step out of the room just briefly because I can be intimidated with my uniform, and then have that mental health worker assaulted. Now I've got a different scenario going on. So we want to make sure that that care that they're getting from a mental health professional can be done so safely and with some trust and care. And so I don't have a definitive answer on, hey, this is the cookie cutter, this is when they will, this is when they won't, but more information on that is better. And if that individual is safe, or we can get them to a safe place, sometimes a phone call is enough to where we don't have to intervene personally.
Awesome. The next question is, I work for a community partner and have had situations more than once where I'm unable to get help for a person in crisis. Often there are other factors at play, such as disability and substance abuse. In my experience, it seems that these two factors preclude individuals from getting help. This leads to a revolving door of contact with law enforcement and no results. What does one do when they go through all the correct channels and nothing happens? Is there a point person to contact? It's extremely frustrating to watch people suffer.
Yeah, I completely agree with you that how frustrating that can be. And it's frustrating for the providers when they aren't able to access the help for the individual either. I think this kind of speaks to what Stephanie was talking about, is that our system is full of lots of barriers. And I think what the definition of help means is probably a good place to start. If help means getting them into a placement that is going to be secure, or getting them into residential treatment when the individual doesn't want to go, or or they weren't accepted, or all of these barriers that we all see every single day of all the reasons why somebody isn't getting the help that maybe we as a family member or a community partner feel like they should get. And so, I think that's really where it comes. NAMI is a great resource for this type of thing, of helping understand the system and what are the best ways to get access to the pieces of the system that you're looking. I think absolutely. I have people reach out to me constantly if they're frustrated about a systems issue. Sometimes it is really a misunderstanding. We can make some phone calls, we can work some things out and all get a better understanding. Sometimes we can't. Sometimes it's just a process issue for a particular resource that's just not going to get us where we want it to go. And so we have to switch gears and start thinking of other ways that we can get the person support and help. And we do that all day long here. And we definitely support people with substance use disorders and intellectual and developmental disabilities and all of the range of different things that can be going on for a person, traumatic brain injuries, all of that can make it difficult to access one resource or another. But I think there's help can come in all forms, I think is what I would say. If you're looking for one thing to be the help, that could be a frustrating process because you may not be able to get that one thing. But if help can look a variety of ways. But NAMI is a wonderful resource. I know many families that are frustrated, just like you, understandably, that I'll say, you know what, you need to talk to NAMI. There's support groups there's education and resource, and they are there to walk alongside families to help them navigate this very complicated system.
Awesome. So is the county, so is the Deschutes County Sheriff's Office and Redmond PD, are they considering starting their own co-responder program?
I'll go for Redmond at least. That is something that we've talked about. Unfortunately, where we're situated right now, we're kind of a little bit tight with resources in our building and things like that. But I think people may have heard we're looking at trying to find a piece of property and to build a new public safety facility in the future. And we've reached out to Holly and Deschutes County Behavioral Health, and we're really hoping that as we move forward with this project, that part of that new public safety facility, being that it's not going to be just a police department, but where we can partner and have a daytime, triage facility up there as well. So we have those resources for Redmond. And then once we have that, have those additional resources, that is something that we've talked about and could explore in the future.
That's a great question. I know that it's been discussed at a deputy level. I can't speak for command up above my pay grade, but I can tell you one of our major issues with that is we're the county, so we're spread out. So if you're in the middle of city and you dial 911, you're going to get Bend PD or Redmond PD. If you live out in the county, there's basically 4 districts in Deschutes County. So to do that, we have a geographic area. It gets a little more difficult to do that logistically. I don't know what that model would look like. I would love it if we could put something like that together, because we do have people with mental health problems and mental illness and other issues in Lapine. We have them in Sisters. We have them in Terrebonne. We have them in Tumalo. We have them East County out in Hampton. So all of that is what we cover. And so it gets extremely difficult to respond in a timely fashion with that type of issue. We are open to suggestions. I think my email is provided. If anybody in the community has suggestions, feel free to email me, because I mean, this isn't just a police issue. It's not just a Stabilization Center and MCAT issue. This is all of our community issues. And just from a police standpoint, there are people out there that are way smarter than I am. And I would love to hear their input, and I'd love to advocate on our side for it. So if there's solutions or people that have seen things, email us, let us know how we can help and get those, maybe not that model, but a different model in place. So.
The one thing I can say about that is that normally clients move around. They drive, they take the bus. And so I've reached out to Deschutes County and Redmond at times when we've ended up with folks in community who have come from Lapine or say Redmond or now in Bend. And we game plan on how to get services for this person. So they don't usually just stay in one location. And that would be the great thing if we had a team that worked together, because we do know most of the individuals and we're able to help each other share information to get the best help and resources that we can for somebody.
This next question can be potentially for anyone. Would you say the majority of law enforcement in our region understand the value of collaborating with mental health professionals?
Yes, I think we are. I can speak from the mental health side of things, and that I've worked in other areas. I've worked in other states, and I've found Deschutes County to be really special and unique in our relationships and our partnerships and our commitment to keeping people with serious mental illness out of our criminal justice system. I mean, it's a commitment across the board, from our DA's office, our county council, all the law enforcement agencies, our community, all our community partners. I think that is a true commitment, and they rely on us to be the experts on the mental health side of things, and we rely on them to be the experts on the law enforcement side of things, and we work together and collaboratively while also having tough conversations sometimes. I mean, it doesn't always go perfectly, and we tried. That's where our CIT steering committee really comes into play, is that we're not afraid to say, you know what, guys, let's talk about this situation, because that one did not go how I think we all wanted it to go. And how can we do better next time? And what is the system gap that we need to work on now? And we tackle it together, and we hold each other accountable in a very professional and respectful way. But we show up every month to that meeting, and we work on these issues together.
And coming from a perspective of not law enforcement, not crisis team, I can say I sit on a lot of advisory committees and consultation panels throughout the community, and almost every single one that I'm a part of has, a lot of mental health workers, and there's always at least one law enforcement representative there in the majority of these, especially when we're talking about acute care cases and things like that. And there's always a passion coming from the law enforcement of like, we want to keep these individuals out of jail if they don't need to go to jail, right? I mean, if somebody's committing a crime, they need to go to jail, that's a whole nother thing. But these individuals that are in crisis and they don't need to be in the jail system, how can we help them? So coming from outside these two different entities, I see the collaboration in a lot of different styles of meetings, different types of meetings. So I would say, like Holly's saying, Deschutes County, everybody involved just really does a phenomenal job of trying to communicate and game plan. And sometimes we just can't really come up with a perfect solution, but there's always effort. There's always discussions open. So I agree that there's just phenomenal collaboration between the two in our county.
I wanted to add too, since you brought up the jail, I want to give a shout out to the sheriff's office because they've been awesome. Our team has gone in to visit clients that are in jail for a prolonged period of time. And they welcome us, the jail welcomes us. They want us to have these open relationships and bring our social workers in or peers in. And it's been very helpful because, again, if they have to go to jail, we try to divert, but if they have to go to jail, at least they don't feel completely alone. We want them to know that resources are still thinking about them, that they're planning when they're released, what the next step is going to be, and that they still have a team.
The next question that we have is, what have the officers' reactions been to the Stabilization Center? Has it generally been positive? Have they voiced any things that they would like to see changed with the Stabilization Center?
So far, the feedback we've gotten from law enforcement is that it's been really positive. We have not received any any negative feedback that they wish it could be done differently. They really appreciate being able to get in and out really, really quickly. All of them have said that to us. We don't have them hang around for a long period of time asking them a bunch of questions. We have 5 questions that we ask them, mostly for data collection so that we can kind of get funding. And it's 5 quick questions and they're in and out. So they've had a really good experience from what I've been told, but I will see if law enforcement has any other information that they'd like to share.
I'll chime in here. Doing this for 13 years, when the Stabilization Center opened up, it was such a breath of fresh air. I personally have used that with individuals within my own family, and I have used that continually with individuals within the community here. There was an individual who's no longer with us, but he was a continual problem in Terrebonne. That resource alone saved us hours upon hours of dealing with this individual, because it was a place where he could go, he could be heard, he would calm down, and we could then turn around. If he needed a ride back, we could get him a ride back, or they would give him a ride back, but he would enter back into Terrebonne. He was trespassed from every place you could think of because of his behaviors. And that Stabilization Center saved us hours upon hours upon hours upon dealing with this individual. He's not a bad individual, but his low-level crimes tied up our resources for almost a weekly basis on things that we could have been spent investigating burglaries, investigating DUIs, investigating things that were of greater need. But this individual, because of his moment of crisis, the Stabilization Center, I can't praise them enough. They were that gap that we needed filled. And if anybody's looking to donate a non-charitable donation, donate to them. And I mean that absolutely sincerely, because it is a gap that has been filled, that has alleviated a line of work that I don't deal with. I'm not a mental health professional. That's not something, I don't receive clinical hours and training like these folks do. That's what they love to do, and they do a great job at it. So yeah, I sing your praises all the time. So thank you.
I would just echo what Kevin said. They've saved us a ton of time up in Redmond. Again, lots of folks that we would be sitting with at the ER for hours upon hours, or maybe having to, try to figure out the jail or some other solution. Again, it saved us a lot of time. The only complaint is that it's in Bend and not in Redmond. But that's why we're talking about trying to get one up here in the future with the public safety facility. But other than that, no, it's great.
Even despite the drive, we're still seeing about 16 to 17% of people that we're serving are from Redmond and coming from Redmond. So we hope that number will continue to go up as we realize it's on the north end of town in Bend. But I agree. I think a triage center in Redmond would be really cool so that, again, you guys could quickly drop somebody off. We could figure it out and we could get them to Bend to the full stabilization center services. And so I think there's work to be done on the horizon there.
And I want to add too that when you talked about families, people may not also think about that when a teenager goes into crisis, they can go to the stabilization center and seek services, or we can take them to seek services. So it doesn't just have to be a family unit. That might be ideal in some circumstances, but certainly we can take younger people there too.
So I have 3 questions about the Stabilization Center that I think Holly could answer for us. So the first is, are there mental health peer supports included in the staffing at the Stabilization Center? What programs do you refer people to once they leave the Stabilization Center? And on average, how many people come to the Stabilization Center on a regular day?
Yeah, those are all really great questions. And I should have mentioned that when I was talking about the Stabilization Center, because one of my pride and joys is that we have a multidisciplinary team approach here at the Stabilization Center. So yes, we have our master's level clinicians that do the risk assessment, and they're phenomenal. But we also have peer support specialists that have lived a life experience, that are able to walk alongside folks and support them in a way that is different than therapy or assessments and all of that other stuff. It's a component that's critical to the success of the individual. We also have case managers who are amazing and move mountains and getting these barriers that we've been talking about moved aside. I could tell you some stories. It's just incredible the work that they do at getting people set up with the Oregon Health Plan, getting them housing resources, getting them food resources, tents and sleeping bags and whatever, hotel rooms, or, whatever, coordinating with family members. All of that stuff is just part of the work that's being done here. And really cool thing that we do here too is that our front desk are behavioral health technicians. So these are people that have knowledge and experience working in the mental health system, and they're at our front desk. So the minute somebody walks in, they're not running into a barrier of somebody who doesn't understand how to manage someone in a crisis or how to help somebody in a crisis. These are people that do know how to help someone in a crisis. And in fact, they get up from their front desk window and they go into the lobby and they can sit down and do paperwork with the individual if that's what the individual needs, and start the de-escalation process and support process right there in the lobby. So I think that's, again, how we differ from an emergency department, in that we have that multidisciplinary approach and full, well-rounded support for the individual that walks through our doors. In terms of where we refer people, we refer people all over the place. We definitely refer people. We get people that are set up with outpatient clinics that are not with Deschutes County, so outpatient providers that refer people to us. We coordinate back with them. We have our case managers are also certified alcohol and drug counselors, so they can do the assessments necessary to get somebody in inpatient treatment or outpatient treatment. And we do that all the time. We refer people to detox. We refer people to Brooks Respite, which is a resource in Redmond. That's a longer term respite facility. They can stay for multiple days. We refer people to St. Charles Hospital and advocate for admission there, and support people in Sageview and Pez. So the gamut. If it's available to us, we know about it and we utilize it. And we do lots and lots of care coordination as well. An average day here, we just hit our year mark on June 1st. That's been our 1-year anniversary. It's a pretty exciting day. And we're averaging about 8.7 people a day. And so that's pretty good for having opened in a pandemic and being a pretty new resource to the community. And I think we were fortunate in that we have these relationships, these partnerships already established. So when we opened our doors, they knew to go, we had the trusted partnerships. So we already had business day one. And so I expect it to grow from there. But we are pretty busy here most days, but still able to serve people quickly. And we're not maxed out in capacity yet.
So last question we have, has there ever been any thought put into either an unarmed unit of the police department who only deal with mental health crises, or putting a policy in place to lock up sidearms when any officer is responding to such a call?
I'll start on this one. As far as the policy and locking up a sidearm, I don't think we've discussed that, but there has been discussion about, some sort of unarmed, whether it's police officers or somebody else responding to those calls. And again, that was kind of the genesis of what we're working on with this pilot program. And I know you've heard us talk about it multiple times during this presentation, but again, that's ultimately what it's going to be. But rather than being law enforcement, you're going to be getting two, licensed clinicians, healthcare professionals, mental health professionals that are trained to do this. And that's ultimately going to be the goal, hopefully, that when those calls come in to dispatch to Deschutes County 911, if they meet the criteria, they can be directed to those workers over at the Stabilization Center, to the MCAT team. And then that pair of folks can go out together, and they would be two folks, not in uniform, not police officers, not armed, and would handle those situations. So that's where that idea has kind of come from, and that's what we're trying to pursue moving forward. And I'll leave it open for either Liz or Kevin as well.
Yeah, we haven't had the discussion of not having a police officer appear as a police officer, and that also means having their tools available to them. On the other hand, I certainly do understand trauma, and I understand that folks who have had trauma in their background and the uniform might be part of that trigger for trauma. Having said that, that's why they're looking at these deployment options for teams as long as it is safe. We have to be very cognizant that we keep our social workers safe as well. And we know that sometimes in the face of crisis, if somebody is very dysregulated, that it doesn't guarantee everybody's safety depending on what's occurring for that person in the moment. So again, I think we have to be very careful that we don't disarm police officers, but that we do have mental health professionals that can go to those calls that qualify where they're going to be safe in responding.
I'll just chime in real quickly. I like the idea of letting cops be cops and let us do cop things where we're trained, and letting mental health professionals do mental health professional things where they are trained. I tip my hat to anybody who steps into the mental health field. That is a very complicated and complex arena, and it does allow for some specialized, very good training. And those folks that I have dealt with are outstanding. And I would love to see some type of team like they're talking about, or some model go into where I can investigate crimes and they can deal with folks who need mental some help in that arena. And that way we can continue to perform well in our specialities. I don't know what that model looks like, but I'm always open to looking into anything to see what we can't figure out. So.
All right, and I think that about does it for our questions this evening. So I will turn it over to Paige. Thank you all very much for attending.
Yes, and thank you to all of our wonderful panelists. We could not do this without you. We appreciate your time and your answers. And we invite anyone watching to follow up with us if you'd like to connect directly with these people, these wonderful resources in our community. These are such important topics and such important issues, and we are really grateful to have the space to discuss them. This program and so many more are available for free at the Deschutes Public Library YouTube channel. Check us out and let us know what else you want to see coming to your Deschutes Public Library. Thank you so much, everyone. Have a good night. We'll see you next time.